I will tell you, it's hard to determine a posterior rupture, even on MRI, even a small one, because when you start pushing it around and applying pressure to the device, what happens? It squishes out. But on MRI, you're never, ever going to see this because you're not applying pressure to the device. I mean, it can't squeeze out. So if you came with an MRI, I would say that is great. You brought me your MRI. I've read through it. It says you have a rupture or you don't have a rupture. If you don't have a rupture, I don't believe the MRI because I've operated on people with normal MRIs who are ruptured. If it says it has a rupture, for me, the plan is no different. I do the exact same thing because I either think you have a rupture or you could have a cancer. So if you're already prepared for all those situations and you're treating everybody, collectively the same way, where you're trying to do a safe procedure to, maximize their long-term health by removing entire areas safely and effectively, then on the back end, when you're getting path reports back, I anticipate all mine to be negative. Clear margins if there's cancer, just like the patient I mentioned to you that had a lymphoma. So to date, I've done over 500 of these. I have found 2 cancers. One was pre-explant, and the patient went on to have mastectomies. And I did the explant with the mastectomy surgeon at the time in the reconstruction when I used to perform reconstructions. And then the second patient who had a breast cancer was this lymphoma that we found, but the margins were completely clear because we did the procedure properly and did not violate the capsule in any way during the procedure. So I felt very good for her after the fact that we were able to complete that effectively. And she has no long-term health consequences for that. She doesn't require any further treatments. She's monitored annually, and I see her annually as well.